Hey everyone. Okay, I'm just going to do a brief recording, even though we're going to cover this in class, just to help you with your studying. I put module 3. You know this is Unit 4 anyway. It's our 4th exam. So, Parkinson's disease, drug management. Parkinson's is a chronic progressive neurodegenerative disorder that affects our dopamine-producing neurons in the brain. The drug management it doesn't cure it, doesn't stop it, doesn't even slow it down. It's just to do your best to manage the symptoms that are affecting their activities of daily living or their quality of life. It's very important to teach them about their medications, what they're taking, why, interactions, the purpose of them, adjustments that may need to be made, and doing this to the patient, the family, and to do teaching, putting your teaching in writing also. Just a quick little picture on your dopamine and acetylcholine to help with understanding the problem that's happening with the chemical imbalance with your dopamine and then the overactivity of your acetylcholine. So levodopa, carbidopa, you might see it that way. You might see it as carbidopa, levodopa, which brand name of cinnamon. Sometimes a provider will choose to start the person on just the levodopa. Levodopa is converted to dopamine in the body. And they said sometimes they'll start with it alone. If the person is starting on just the levodopa, you need to teach them to not take any multivitamin mineral compounds because B6, which will be in these multivitamins, minerals, decreases the effectiveness of the levodopa. And if they start on levodopa, then they add the carbidopa. The carbidopa purpose is to carry the levodopa into the brain where it can be used. And if you see here, it's a dopamine precursor, a replacement, or it's converted to, levodopa is converted to the dopamine. And the carbidopa preventing breakdown, drug of choice for later stages, started when symptoms start to interfere with their functioning and activities. So caution any disorder impacted by an increase in cholinergic effects. Contraindicated with closed angle glaucoma. It's an oral dosing, preferably on an empty stomach. It has interactions with several drugs, antipsychotics, MAO inhibitors, which one of your one of your Parkinson drugs class is an MAO inhibitor. Rasagiline and selegiline are MAO inhibitors, which sometimes is given as an adjunctive. So obviously you would not want to put somebody that's on levodopa, carbidopa on an MAO inhibitor such as rasagiline or selegiline because of a drug interaction. Also interacts with several antihypertensive medications like lisinopril and amlodipine, the ARBs and the ACEs, which we'll be covering next unit. Teaching that it takes about 3 weeks to show effectiveness after starting levodopa, carbidopa. Some side effects: involuntary movements, nausea, vomiting, anorexia. Another I didn't list on here is having your sweat, your urine, some of your body fluids getting a dark color, which is a benign finding. It can happen. It's nothing to worry about. Adverse effects: CNS and psychiatric disturbances are possible. Also possible to have an overstimulation in the parasympathetic nervous system leading to arrhythmias, in seizures. Contraindicated with also if somebody has a history of cardiac arrhythmias and seizures, glaucoma, there's caution with giving this because of the overstimulation. If it's a controlled release, obviously you're not going to crush it. Also, teaching people that not to take with high protein foods because it will decrease the absorption. Okay, so the next class is your dopamine receptor agonist, pramipexole and ropinirole. Um, Action is to stimulate the dopamine receptors. Caution with a history of hypotension, hallucinations, and renal impairment in elderly. So renal impairment, remember you're looking at your BUN and creatinine. If they're elevated, that's some renal impairment. Contraindications and using with adrenergic drugs. Adrenergic, that's the sympathetic side, the fight or flight, so your dopamine, epinephrine, and norepinephrine. Adverse effects, edema, fatigue, syncope, drowsiness, and GI upset. Ropinirole, it's a dopamine receptor agonist listed here, is also can be used for restless leg syndrome. Okay, so your MAO inhibitors, which I mentioned earlier, because you don't want to give an MAO inhibitor with levodopa carbidopa. The two here, rasagiline and selagline, are selective, less likely to have a problem with the tyramine. It can still happen, the cheese and wine, but it's less likely because they're selective. Anyway, action increase the level of your dopaminergic stimulation in the CNS. It can be used by itself or adjunct with another Parkinson medication for better management. Adverse effects, headache, insomnia, dizziness, hypotension can be orthostatic or just plain orthostatic hypotension or just hypotension, rash, and weight loss. Major drug interaction with meperidine, which you may know as Demerol. Your COMT inhibitors, entacapone and tolcapone, prolong the duration of action of levodopa. So this would be given as an adjunct because you have to be on the levodopa for the duration to be prolonged. So it's given in as an adjunct and contraindicated in the liver failure. Adverse effects, GI upset, dyskinesia, urine discoloration. COMT is an enzyme that catalyzes the breakdown of the body's catecholamines. So your catecholamines are on that adrenergic, your fight or flight side. So if you are inhibiting that breakdown of those catecholamines, that's why it's helping with your prolonging the duration of levodopa and helping it last longer to stop those adrenergic or cholinergic problems. Okay, so your anticholinergic, benzotropin or cogentin, which is to block the effects of the acetylcholine. It is also used as an adjunct because it's to decrease tremors and cogwheeling. So it reduces that excessive cholinergic effects. Some of the adverse effects are tachycardia, disorientation, and toxic psychosis. Caution in hot weather and because of the severe risk of hyperthermia, making sure they stay hydrated. There's a few contraindications like alcohol and caffeine, both which can counteracts the effects of the anticholinergic, both can. Teaching or because of the dry mouth, I didn't put that up here. Adverse effects, of course, on anticholinergics are they can't eat, can't see, can't pee, can't eat because of the dry mouth, possible problems with urinating. So for the dry mouth, you're going to teach them to have some kind of hard candy. Photophobia, because of the dilation, you're going to wear sunglasses and never stop the medication, the anticholinergic, suddenly. Your last one, your dopamine modulator, is amantadine or Simitril, which you'll know as an antiviral for flu. It releases dopamine and other catecholamines from storage, blocks the reuptake of the dopamine, and has some anticholinergic effects. It's used just in the early stages of the disease. Major adverse effects are dizziness, insomnia, and nausea. So with the action, it improves the neurotransmission because it results in higher levels of dopamine actually in the nervous system. So now we're going to go into the drugs that you need to know for coronary artery disease. And start with the ones to lower your lipids or your fats. You have omega-3 fatty acids. They reduce cholesterol. Major adverse effect with the rash, burping, allergic reactions. Keep in mind that there's a drug interaction with anticoagulants such as your Coumadin, heparin, anything that's going to prolong your bleeding. The omega-3 fatty acids can exacerbate that. Contraindicated in pregnancy and allergy to fish oil. So your statins are all your ones. I didn't put the names here. It's the pravastatin, atorvastatin, simvastatin, or suvastatin. They all have the statin in their name. They are the first-line therapy for high cholesterol. Contraindicated in pregnancy and if they have an elevated liver enzymes or liver disease. So some monitoring you will be doing, of course, is your liver enzymes, your AST, ALT. It is broken down in the liver because that's where your fats are formed. So it can impact the liver enzymes and you're watching for an elevation. Adverse effects: abdominal pain, rash, headache, myalgias. Myalgias is when you're watching your creatinine kinase because of possible muscle breakdown. What else? Second slide for that. Once daily dosing, it's best to take in the evening when your liver is more active, creating these lots of drug interactions, just like here's with your anticoagulants, just like your fish oil can increase the effects of anticoagulants. Okay, so rhabdomyolysis, the breakdown of muscle, which is the greatest risk with statins, interactions with anticoagulants, erythromycin, HIV drugs, all the antifungals, azoles, diltiazem, which is a calcium channel blocker, grapefruit juice. Never ever take grapefruit juice if they're on a statin because the risk of having that rhabdomyolysis or muscle breakdown is really high. And gemfibrozil, which is one of your fibric acid drugs for cholesterol. So combining a statin with a gemfibrozil or fibric acid increases the risk of having rhabdomyolysis. So your drug monitoring, your lab monitoring, I said, are your liver enzymes. Also, you're checking for effectiveness of your statin. So you're monitoring your total cholesterol, triglycerides, your HDL, which is your good cholesterol, your LDL, which is your lousy cholesterol, along with your liver enzymes. Okay. Bile acid sequestrants, cholestyramine and cholestyramine both have that choline name in it. Those are your bile acid sequestrants. They bind the bile necessary that's needed to absorb your cholesterol. It's second-line therapy for high cholesterol. Sometimes it's the primary if they can't tolerate a statin, or it's preferable to be adjunctive, like to do a statin and add this into it. Contraindicated with biliary or bowel obstruction because, of course, you don't want to bind the bile if they have a problem with biliary obstruction. Adverse effects are your constipation, bloating, belching, heartburn, nausea. Interactions decrease the absorption of your fat-soluble vitamins, your fat-soluble, your A, D, E, and K. When we start talking about your anticoagulants, we talk about vitamin K because it's your what do you call it, for your Coumadin, warfarin, to reverse that bleeding. You give vitamin K. Vitamin K is needed for your clotting. So if somebody's on a bile acid sequestrant and they start having a bleeding problem, you're going to check the vitamin K because it may have been blocked, or you're going to check your clotting times, your bleeding times, your PT, INR to see if that bleeding time is prolonged. Taking other medications an hour before or 4 to 6 hours after taking your bile acid sequestrant because it'll mess up the absorption. Okay. Niacin or nicotinic acid increases activity in lipoprotein lipase. It's great to reduce your triglycerides. It can also lower the cholesterol and increase your HDL. Major adverse effects you are going to teach them is the flushing pruritus, which is itching, and GI distress, mainly nausea. Take it with a low-dose aspirin or an NSAID 30 minutes prior to the dose, taking it with a low-fat snack in the evening. And if they're on a statin, taking niacin may aggravate and increase the muscle aches. Okay, your fibric acid agents. Gemfibrozil was mentioned earlier. Gemfibrozil and fenofibrate. It's got the FIB, the fibrate in the name. A fibric acid agent. Activates your lipoprotein lipase, mainly used to lower triglycerides and increase HDL. Contraindicated in severe liver or kidney disease and gallbladder disease. Main problems with it is the abdominal discomfort, diarrhea, and nausea. Sometimes they'll have headaches and blurred vision. Mostly I've seen the abdominal discomfort, nausea, and diarrhea. Interactions, again, all of these anti-lipids increase the effects of your anticoagulants. All of them seem to interact with your statins and increasing your risk of having myalgias. You can possibly have a decrease in your hemoglobin, hematocrit, and white blood cells, and it may increase your bilirubin. Okay, that's the last on those. We're going to go into your deep vein thrombosis or anticoagulants. Just a picture of your coagulation cascade. Drugs that prevent formation of a clot by inhibiting certain clotting factors. So some need blood work, some do not, depending on where it is occurring in their clotting cascade. The anticoagulants do not dissolve a clot. They only prevent a clot from forming, depending on where they're working, because it decreases the ability of the blood to coagulate and form a clot. Some are oral form, some are parenteral, whether it's sub-Q or IV. And teaching on anticoagulants, because if something happens to them, people need to know they're on an anticoagulant, so they need a medic alert. teaching them to avoid aspirin and nonsteroidals because of interaction in your clotting times, increased risk of bleeding. That some of them, depends on which one they're on, may need scheduled blood work to monitor effectiveness and if the levels get too high. And avoiding safety issue is using an electric razor, not a razor blade, because of the risk of bleeding. And of course, contraindication for anticoagulants is if the person has a history of ulcers, or precisely if they have a current gastric ulcer or peptic ulcer. Okay, so we're going to talk about your heparin. There is the regular unfractionated heparin that's given IV intravenously. It has a very, very short half-life, 1 to 2 hours. When you're on a heparin infusion or heparin sub-Q, you monitor their PTT, partial prothrombin time. You want, if therapeutic is for your PTT to be 1.5 to 2 times the control. So if your PTT is greater than 2 times your control, it is too high, you need to stop your heparin and call a provider and possibly prepare to give your reversal drug, which is protamine, with your heparin. Your low molecular weight heparin, enoxaparin, is the only one I listed on here, or you may know it as Lovenox. It is given sub-Q. It's great because it has a greater bioavailability than heparin does. Heparin breaks down too fast. And so your enoxaparin, it can be given like once a day or once every 12 hours because it has a much longer half-life than your heparin does. So your anticoagulant response is much more predictable, so it's a lower risk of having a heparin-induced thrombocytopenia. It can be self-administered, taught to give themselves the sub-Q injections, and it doesn't require them having their PTT lab work done. Either of the heparins, unfractionated or low molecular weight, adverse effects of bleeding, hematoma, mentioned thrombocytopenia, which is greater risk in heparin than low molecular weight, although it's there. I think that's it. Let's see, your warfarin or Coumadin inhibits your vitamin K synthesis. So obviously to reverse it, you're going to give vitamin K. Contraindicated if they have an active bleeding process and pregnancy. Adverse effects, skin necrosis, so I talked about the purple toe syndrome. And it's oral dosing, and it is monitored. Oops, I think it's next slide. Lab monitoring is your PT-INR. Again, your therapeutic is your 1.5 to 2 times the control. Therapeutic INR is usually 2 to 3.5. A normal PT usually ranges between 11 and 13.5. So just you're really looking at your PT being between 16 and 27, mainly looking at your INR of 2 to 3.5 is about the range you want it in. So if you have a INR that's 6, 7, 8, it's obviously too high. You need to notify the provider you're watching for bleeding and you're possibly giving the vitamin K for a reversal. Vitamin K is best administered IV because it takes a long time, 6 hours given IV, but up to 42 hours to be effective if it's given orally. Major drug interactions, so ones that increase the anticoagulation action, so the higher risk of bleeding if you're on warfarin. If you take it with acetaminophen, I should have put NSAIDs on here because NSAIDs, aspirin, cimetidine, which is Tagamet, garlic and ginkgo. Garlic and ginkgo are are often taken as over-the-counter supplements or herbs. You decreasing the anticoagulant action are barbiturates, phenytoin, which is dilantin, and another herb, which is St. John's wort, will decrease the effectiveness. So increased risk of bleeding with the top list there. Okay, so direct thrombin inhibitors, that's exactly, they work directly on the thrombin factor. It's to treat active heparin-induced thrombocytopenia. It's given IV. Dabigatran is the one to remember. It's to prevent strokes in people that have atrial fib. If there's decreased renal function, the dose is adjusted appropriately to that. There's obviously an increased risk of GI bleeding, and don't give with any other anticoagulants. Has lots of drug interactions like warfarin. Your factor XA inhibitors, Apaxaban or Eliquis, and your rivaroxaban or Xarelto, which you've probably seen them both or heard on commercials. They're given an oral route. It's to reduce the risk of stroke and embolism in atrial fib, and often given post knee or hip surgeries because the risk of throwing a clotted DVT. Caution in severe renal impairment. Adverse effect obviously is bleeding. There's a black box warning to not discontinue prematurely because it can lead to an increased risk of clots. It has a good, reliable bioavailability. It reversible direct inhibitor of free and clot-bound factor XA. And because it's a direct inhibitor, it works to prevent, in the final steps of the blood clot formation. So because it's in that final step, it's not in the earlier part of the cascade, so you don't need any blood work to monitor it. That's it. So your oral antiplatelets, the first one is your aspirin. Works to prevent the platelet adhesion at the site of vessel injury. Antiplatelet effects last 7 days, so if they're going to have a procedure and they're on aspirin, it needs to be at least 7 days before any kind of surgical procedure because they need to get their platelets working appropriately at a vessel injury. Adverse effects are drowsiness, dizziness, confusion, nausea, vomiting, GI bleed, and blood dyscrasias. Contraindications of obviously active bleeding, any kind of traumatic injury, if they have a GI gastric ulcer, leukemia. Interactions with NSAIDs because it increases the risk of bleeding. Blood dyscrasias or thrombocytopenia, agranulocytosis, leukopenia, neutropenia, hemolytic anemia. That should be it. Okay. Your other oral antiplatelet is your clopidogrel or Plavix. It is used here, ADP inhibitor used to reduce thrombus risk, reduce atherosclerotic events in acute coronary syndrome. People can be placed on it when they have a stent or something in to reduce clots from forming on there. Also a major treater for peripheral arterial disease, PAD, because of the arterial blood flow. Contraindicated with active, just like your aspirin, your active bleeding, leukemia, traumatic injury, GI ulcer. Lots of drug interactions. NSAIDs, just like with your aspirin, NSAIDs can increase your risk of bleeding when combined with clopidogrel or Plavix. PPIs, which are your proton pump inhibitors, omeprazole, pantoprazole, your calcium channel blockers, your amlodipine and diltiazem, or your calcium channel blockers. These will decrease PPIs, and calcium channel blockers decrease the effectiveness of the clopidogrel. Adverse effects: chest pain, edema, headache, dizziness, fatigue, abdominal pain, diarrhea, rash, and pruritus. This is your last slide. Your intravenous antiplatelets, eptifitabam or integralin, and torabin or agrestat will block the receptor protein in the platelet membrane wall, used in unstable angina, MI, coronary procedures to prevent formation of thrombi. I'm not going to really go into this here because we're going to use it more when we get into MIs and other things. We'll talk more about using this type of infusion. Okay, so that is the end of your recording.